Good morning. I am here to represent on behalf of Dr. Velepio-Kello, who unfortunately was unable to attend. But I wanted to start with a thank you, actually, for many of you in the audience here who served as close thought partners and advisors in the early days of this study as we were thinking through how to put this together. And so I'm delighted to be here today to share some early experiences as we get started in Swaziland. To give you a sense of where our study is, it's located in Swaziland, which is a small country in southern Africa with a population of about 1.2 million and a very high prevalence rate. Since 2004, the Swaziland National AIDS Program has made significant progress to increase coverage in the country, but has continued to struggle with containing the epidemic. And so, several years ago, when HPTN 052 was announced, it was seen as a really exciting opportunity for the Ministry of Health to start exploring this new scientific breakthrough as a way to potentially turn the course of the epidemic in Swaziland and also improve the health outcomes of people living with HIV in Swaziland. As you can see, there are actually two studies underway right now in Swaziland. One is the MaxArt study, which I'll be presenting on, and the other one is MSF study, which is in the south of the country. We've been collaborating and coordinating closely with the government to make sure that we're sharing information and working closely together. What I think is exciting about our study and makes us a bit different perhaps from some of the other studies that have been presented here today in some way is that we're working through a consortium of partners that includes both the Swaziland Ministry of Health, who's leading the study, but also social science researchers, economists, community groups. And we've really, I think, been able to leverage this multidisciplinary group of partners to identify and focus in on questions that will allow us to really be able to get to a better understanding of how to take treatment as prevention to scale in a resource-limited setting through a myriad of lenses. So when we started putting our design together, we realized very quickly looking around that there were many other clinical trials presented this morning that were much better positioned and resourced to really investigate some of the clinical outcomes of going to treatment for all. And what the Ministry of Health in Swaziland was really eager to understand were more the implementation questions. If it was to move forward with this new intervention, what are the issues that it would need to address in order to make sure that it was feasible, acceptable, scalable, and also to better understand the affordability of this intervention. We continue to also prioritize the clinical outcomes of the study to make sure that we're providing and not compromising high-quality patient care. But the focus of the study was really to narrow in on some of these implementation questions that we felt needed to be answered in order to present the Ministry of Health with good evidence to consider as they looked at potentially taking this to scale. The design is a stepped wedge, which is being conducted across 14 government-managed health facilities over a 3-year period. At this point in time, it's very early on. We've just transitioned over 2 facilities, and we're about to transition 2 more. We're offering open enrollment for all HIV-positive adults who are above 18 or over, and excluding pregnant and breastfeeding women, which, to be clear, is because the country has already moved over to option B+ as their guidelines. To give you a sense of just the study population, we're finding that the enrollment is actually very similar to the national trends. So it's primarily a female population with newly diagnosed clients enrolling with low CD4 counts. And we're also finding that as we as we go through the transition for each of the sites, just managing some of the logistics of making sure that we can consistently be gathering the CD4 data that we need for us has been a bit of a learning curve, and just trying to really manage and make sure that we're monitoring our CD4 statistics continuously. So this is definitely for us an area where we're continuing to work within the national system, but looking to improve. When looking at acceptability, we've been pleased to see that there's some promising trends with high uptake. As I mentioned earlier, we've transitioned over 2 sites, so this is very early data and obviously a small sample size. But what we found helpful about this is that I think early on we were concerned that health workers would be somewhat resistant to transitioning over to a treatment for all approach because of the fact that patient loads at some of the facilities where we were working were already quite high, and there was a perception that this would increase the number of patients coming in, increase their workload. But actually there's been anecdotally quite a lot of support from health workers and excitement to be able to initiate clients upon their arrival at the facility. We've also found that we've had really good and promising quick time to initiation. So clients are offered ART upon being consented. And both when considering newly diagnosed clients and returning pre-ART clients, we've found that there's been quite a bit of acceptability to initiate right away. This is actually where our social science team has been spending a lot of time really trying to understand for the clients who do not initiate, what are some of the reasons, what are some of their perspectives, really trying to understand across the population some of the more qualitative data and experiences that we want to make sure we're taking into consideration as we look at just the trends across the population. Another component of the study is that we've also been leading a fairly robust economic evaluation. Obviously, one of the biggest questions around implementation is around affordability. And so the economic evaluation is broken into 2 phases. There's first patient exit interviews, and then also pretty thorough bottom-up and top-down costing. For the exit surveys that we've been doing with patients, what we've been trying to understand is the out-of-pocket costs that patients are experiencing for their visits to the facility. And it's perhaps not surprising, given other research, to see that much of those costs are centered around transport and lost income. But what's been helpful for us to see is that while the costs are not insignificant, they're not catastrophic, meaning that within the general monthly income for most people living in Swaziland, this was still seen as something that would be affordable and manageable. But obviously we're going to be continuing to better understand this also through our social science lens to make sure that we're fully understanding these perspectives. So as I mentioned, we're also doing costing across all of the facilities, both in the control period where facilities are working to initiate clients under the current guidelines in the country, and then also during the transition phase when the facilities have transitioned over to a treatment for all perspective or approach. And what's helpful about this is that we started this with really trying to do some preliminary modeling so that we could understand, even just from the highest level with data that we did have, what were the cost implications of trying to move Swaziland from the 2010 guidelines to a universal treatment perspective. And what we'll be doing as we go through the study and get towards our conclusion is bringing in that data from the costing studies at the facilities to really refine and improve and validate these early preliminary results. But what we've seen is that even just from our early modeling, you can see that the incremental cost, upfront cost of moving to universal treatment is about a 30% increase for the country, but over time we're confident that those costs will start to become more affordable with the consideration for the long-term benefits of having people on treatment earlier with better health outcomes and reduced new infections. So finally, I think one key takeaway for our study has really been that this implementation research is extremely timely. I think it's so exciting to sit here today and see all of this new evidence that's coming out in support of moving to a treatment for all perspective and approach. But what's still left, I think, for us to untangle and better understand is how to make this affordable, how to make this feasible and realistic for the countries where some of the benefits of this approach could potentially have the biggest impact. And so we're going to be continuing, obviously, with our study and trying to tease out these hard questions so that we can come back and be able to report Swaziland's experience and also help inform their steps moving forward. Thank you very much.